Hello, everyone. I'm Shri Vallabhaneni, a Cardio-Oncology Fellow at University of Pennsylvania and WashU.
And I'm Bénédicte Lefebvre. I'm also a Cardio-Oncology Fellow at the University of Pennsylvania.
Today, we'll be presenting the Journal Club an article which was published in JACC Cardiovascular Imaging titled Serial Cmr Strain Measurements to Identify Cardiotoxicity in Breast Cancer Patients, how this compares to ECHO.
So to start with, I'm just going to give a little bit of background. So we know that doxorubicin-induced cardiovascular dysfunction occurs in 10 to 15% of patients at a dose of 240 mics per square meters. And cardiotoxic effects worsen with higher dosage and in combination with trastuzumab and or chest radiation therapy. And that doxorubicin with trastuzumab result in LVEF declines in up to 33% and severe heart failure in 2 to 4%. And finally, the development of LVEF declines and heart failure result in treatment interruptions, inferior oncologic outcomes, and worse overall survival. And I know this audience is very well known of what is strain, but given that this is a paper about strain, I'm just going to go over a few of the principles. So strain is a measure of the formation of cardiac fiber from the contracted state to the relaxed state. And we can measure it in 3 directions, in the longitudinal, the circumferential, and the radial. And here's an example of GLS by echo. So you have the apical 4 chambers to your left, the 2 chambers, and the apical 3 chambers to your right. And this is a depiction of an abnormal strain. It was measured in this patient at minus 9.6%. And we know that normal LV strain values changes according to the vendor and the software. So that's why it's important to use the same vendor and software throughout the treatment of your patients. And although the normal value changes according to the software and also to the vendor, we usually consider that strain worse than minus 16%, so more positive, to be abnormal. It's considered to be abnormal. And GLS is also a function of age, weight, and systolic blood pressure. But there's also other factors that are affecting the strain value, such as the hemodynamics, the chamber geometry, the infarction, and the synchrony. And strain is also load dependent. It's a function of LV size. In the CMR analysis, there was associations between declines in GCS and LVEF according to the LV volumes. And global longitudinal strain is widely studied for the detection of subclinical LV dysfunction, and I'm going to go through some of the important paper. And there is potential incremental utility over LVEF. However, it needs to be derived from high-quality apical 2, 3, and 4 chamber views. You need excellent endocardial definition, reliable speckle tracking, appropriate frame rate, so usually more than 40 to 50 frames per second, at least 3 cardiac cycles in each apical view, similar RR interval, and also no use of ultrasound and enhancing agents.
So why is strain important? With initiation of potentially cardiotoxic chemotherapy, you can have a reduction of your contractile reserve. And before you have a drop in LVEF, you could see a decrease in your systolic myocardial deformation. And this is what strain does. It identifies the decrease in the systolic myocardial deformation and detects subclinical cardiotoxicity. Our thought processes with identification of these patients early and initiation of cardioprotective therapy, they can have a complete response versus a partial response with improvement in their contractile reserve. Versus if these patients go unnoticed and over time, they can have a drop in LVEF over years, and with initiation of cardioprotective therapy, then they may have very minimal response.
So some of the papers that shows the use of GLS in the cardio-oncology patients. So this paper published in 2012 showed that GLS can predict future cardiotoxicity events. So they used 81 women with HER2 positive breast cancer that were treated with anthracyclines, taxane, and trastuzumab. And they did echo and also high sensitivity troponins and NT-proBNP every 3 months. And they showed that there was a LVEF decline from baseline, so a mean of 64% to 59% at the end of the 15 months period. They had 26 patients, so 1/3 of the cohort that developed cardiotoxicity. 5 of them had symptoms of heart failure. And what they saw is that GLS were worse than 19% in all patients who develop congestive heart failure. And their conclusion was that GLS and high sensitivity troponins I measured at the end of the anthracycline treatment was predictive of cardiotoxicity. A systematic review that was published in 2014 of more than 35 articles showed that concluded that a 10 to 15% early reduction in GLS by speckle tracking echo during therapy appears to be the most useful parameter for the prediction of cardiotoxicity, as defined as a drop in LVEF or heart failure. A more recent meta-analysis published in 2019 of 21 studies and more than 1,700 cancer patients, their incidence CTRCT was between 9 and 44%. And what it showed is that worse GLS during treatment was associated with higher CTRCT risk, with odd ratios of more than 12. And also, relative change in GLS was associated with CTRCT risk, with odd ratio of more than 15.8. However, they were unable to identify a GLS cutoff value to predict cardiotoxicity, given a different CTRCT definition and also some publication bias. And most recently, the SUCO trial, the one-year result was published. And I'm sure like this audience is very well aware, there was two arms, more than 300 patients treated with anthracycline, an arm that was LVEF guided therapy, the other one a GLS reduction therapy. And although it didn't show a difference in their primary endpoints at 1 year, meaning that the EF in both arms were the same at the 1 year period, there was a significant difference in the people that received the cardioprotective treatments and in people that were treated. So in the GLS guided arm, there was a decrease of only 2.9% in their EF. However, in the EF guided therapy, there was a decrease in the LVEF of more than 9.1%, so a significant change. And all these papers, all this research brought multiple guidelines and also position paper. This one is from the JC 2014 that basically show or tell us that a decline of more than 50% is potentially clinical relevant. This is a suggestion. Again, the 2016 European Society of Cardiology position paper suggests also that a GLS relative reduction of more than 15% from baseline is suggestive of a risk of future cardiotoxicity. A recent Primers in Cardio-Oncology also proposed an algorithm with the use of GLS in the low normal LVEF.
So we're going to switch gears here and talk a little bit about CMR strain techniques. There are several different techniques which can be utilized with CMR. Some of them require additional imaging, which are tagging, SENC, which is strain encoding and dense. And there's another way where you could just use the images on SSFP and do post-processing on that, and this is feature tracking. So in tagging, you tag the myocardium in a grid-like pattern, and you track the magnetization tags over time. And it has better reproducibility. It's an older and a well-validated study, but however, the tags fade over time. And some of the disadvantages of using tagging is they have longer acquisition time, prolonged post-processing time as well, and they're also limited by low temporal and spatial resolution. SENC is a newer technique which is now upcoming, and there's data which is going to be coming out about utility of STRENC and cardiotoxicity. It uses the same principle as tagging, but it tags parallel to the image plane and combines that with a phase encoding gradient. It has very short acquisition time, and the processing post is very quick as well. Dense is another technique as well, and this uses tissue and displacement into the phase of an image. And just coming to feature tracking, it tracks the features in the image and recognizes them in subsequent image of the sequence. You do not need any additional images. However, this is limited by motion artifacts, and there's no standardization with feature tracking as well. The current paper used tagging, which is an older method, and feature tracking for strain analyses by CMR. So this is just an example to show how tagging works. Like you tag the myocardium in a grid-like pattern, and with recovery, the tags fade over time, and you're tracking the magnetization tags. Feature tracking is done on SSFP images, and this is a comparison showing feature tracking with echo, and you track the features over subsequent images and over time, and you get a bull's eye, which is kind of similar to what you get on echo as well. So, and then there was this paper which showed that given that there's so many different techniques, like what is the bias between the different techniques with feature tracking, tagging, and saying? And as you can see, there is significant bias between these techniques. So if we are going to use one technique for, in serial follow-up, we should be using the same, especially with CMR, to follow these patients, given the significant bias between the different techniques.
So some of the paper that use CMR in the cardio-oncology patients, so this one was published in 2020. They had 60 patients, 30 HER2 positive cancer patients, 15 of which had CTR-CD, and 30 healthy volunteers. And they basically did CMR and echocardiography every 3 months in that population. And obviously CTR-CD cohort had the larger mean temporal changes in all parameters that they did. In the healthy cohort, the 2D GLS, the 3D LVEF, and also the CMR LVEF had the least overlap and the least mean temporal changes. And basically their conclusion was that the two-dimensional GLS on echo and the CMR LVEF had the lowest inter-observer and intra-observer variabilities in between cohorts. Another paper that used strains of feature tracking assessment in the cardio-oncology population, they had 41 HER2 positive breast cancer women, all treated with trastuzumab, and more than 50% of them treated with anthracycline. They did serial CMR, and what they saw is that GLS and GCS decreased significantly at 6 months and also 12 months, with an increase in the left ventricular and diastolic volume. And there was also significant correlations between the temporal, so between baseline and 6 months, changes in the LVEF, and also all global strain measurements.
So based on the background we have right now, what are some of the unanswered questions? Does CMR, GLS, and GCS changes occur prior to changes in LV end systolic and LV end systolic volume and LVEF? What is the impact of LV volumes on CMR strain analyses, especially in patients who are undergoing cancer therapy, because these patients are prone to dehydration, a change in the LV and diastolic volume, or if they have incidents of heart failure, which can also impact their volumes? What impact does this have on strain analysis? And does CMR LV volumes and LVEF track concurrently with CMR strain? There's also very limited data on the prognosis of serial strain measurements with CMR and echo, and also very limited data on consensus statements in utility of CMR strain in patients undergoing active chemotherapy. So this paper tries to answer some of these questions. This is a prospective study which was done from March 2014 to March 2018, HER2 positive breast cancer therapy patients who underwent sequential therapy with anthracycline and subsequently with trastuzumab with or without adjuvant radiotherapy were included. It was done in a total of 125 patients, inclusion criteria being women 18 years of above or age who received anthracycline followed by trastuzumab. Exclusion criteria if they had a contraindication to CMR, if their life expectancy was less than 12 months, if they're participating in another clinical trial, prior exposure to anthracyclines, which is important, because this can also cause a change in your strain, and if they had a history of active or prior cardiac disease like MI or heart failure. All patients got a baseline CMR prior to initiation of any chemotherapy and an echo as well, and then 3 months after, they got another CMR and an echo prior to initiation of trastuzumab, and subsequently at 6 months, 9 months, and then at 15 months, and an echo in between at 12 months. CTR-CD was defined as an asymptomatic 10% reduction in LVEF from baseline to a value less than 55%, or symptomatic reduction of more than 5% to a value less than 55%. The statistical analysis used in this study, the continuous data was represented as mean and standard deviations or median and interquartile range, categorical data as frequencies, and comparison between CTR-CD and without CTR-CD was done with a student t-test or chi-square test, and a longitudinal regression analysis was used for concurrent effect of CMR and echo measures on LVEF and CTR-CD. Area under the curve was used to compare baseline clinical risk factors of age, cardiovascular risk factors, and baseline LVEF imaging parameters to determine the value of change in indexed LV and systolic volume, LVEF, and for subsequent CTR-CD. So just a little bit about the baseline characteristics in the entire cohort and those with CTR-CD and without CTR-CD. There was no significant difference between both the cohorts. However, you could see that patients who had CTR-CD are slightly older in age and they've received a little higher mean heart dose of radiation. But the incidence of risk factors was quite similar between both the groups. Diabetes a little bit higher in the CTR-CD group, and at baseline, very low use of cardioprotective therapy in these patients. And when the LVEF, the baseline LVEF and the LV volumes and the tagging with the strain with tagging and feature tracking was also similar between both the cohorts, and so was the echo parameters. So among all these patients, like with using CMR, which was done in 125 patients, CTR-CD was identified in 35 patients. Of these, 33 had an asymptomatic drop in LVEF of more than 10 points to a value less than 55%, and 2% of them had a more than 5% reduction to a value less than 55% with heart failure symptoms. Echo was only available in 120 patients, and CTR-CD was identified in 22% of the patients. And in those patients who had CTR-CD, 9 of them had an interruption in trastuzumab therapy for 1 or 2 cycles, and 60% of them were started on a cardioprotective therapy with either beta blockers and/or ACE inhibitors or ARBs. So this is just showing the concurrent association with strain and LV volumes with change in LVEF and CTR-CD. And as you can see on the left, like CMR strain parameters, LV volumes, and echo parameters did predict a change in LVEF at concurrent there was a concurrent association. However, of these, feature tracking with GLS, GCS, and LV end systolic volume and 2D GLS and LV end systolic volume index had a higher impact of absolute change in LVEF. And when it comes to concurrent CTR-CD, absolute and relative changes in feature tracking with GLS and GCS predicted concurrent CTR-CD, and echo parameters with 2D GLS also predicted concurrent CTR-CD. So then how about subsequent change in LVEF and CTR-CD? Tagging did not predict a subsequent LVEF change. However, feature tracking did, and so did change in LV end systolic volume index, not the end diastolic volume index, just the LV end systolic volume index, and so did GLS and echo parameters of change in LV and systolic volume index. And with subsequent CTR-CD, echo change, absolute and relative change in echo did predict a subsequent CTR-CD, and so did absolute and relative change in like LV and systolic volume index. But feature tracking, it was only the absolute change in GCS which predicted a subsequent change in the subsequent CTR-CD. And this is just showing the longitudinal trends of change in strain in strain and LVEF in patients who had CTR-CD and who did not have CTR-CD with MRI and echo. As you can see, these patients who had CTR-CD did have like a change in their strain with GLS and feature tracking and tagging as well. And both groups did have a slightly drop in EF. You could see is also seen in the patients who did not have CTR-CD. However, patients who did have had a more drop in LVEF, and this was more so seen at 6 months. And this was with MRI. And similar pattern is seen in echo as well.
So basically, what did we learn is that relative changes in tag GLS and GCS, feature tracking GCS, and two-dimensional echo GLS are early predictors of future CTR-CD. So a 15% relative reduction in tag GLS increased the odds of future CTR-CD by 47%. A 15% relative reduction of tag GCS increased the odds of future CTR-CD by 50%. A 15% relative reduction in feature tracking GCS increased the odds of future CTR-CD by 87%. And finally, a 15% of relative reduction in 2D echo GLS increased your odds of future CTR-CD by 133%. And it's better to consider relative changes to baseline compared to absolute changes. And also the author performed analysis on three different CTR/CT definition. So from the paper definition, but also from the ESC definition, which is a decrease in your EF of more than 10% to a value of LVEF of less than 50%, and also based on the definition by the ASC, which is a decrease in your LVEF of more than 10% to a value of less than 53%. And basically, the three definition shows the same.
So very few patients with CTR/CD developed heart failure symptoms, and CTR/CD most frequently occurred 3 to 6 months after initiation of trastuzumab therapy. So at 3 months after trastuzumab, it was 40%, and 6 months after trastuzumab, it was 34%. And LVEF change was predominantly driven by an increase in the end systolic volume index, and the change in LV end systolic volume index was prognostic for CTR/CD on future imaging.
And the author also performed the area under the curve. And basically what it shows is if you were to add the echo GLS on your baseline clinical risk factor, there's an incremental value for predictive of CTR/CT. So without strain, your area under the curve is 0.63, and it increases by more than 50% if you were to add the echo GLS. As opposed to if you were to add the CMR feature, it increases between 5 and 9%. And there's also an incremental value of adding your LVEF or your left ventricular end systolic volume index over your baseline clinical risk factors. And the author and we think that the higher LV end systolic volume index reflects worsening myocardial systolic functions. So some of our thoughts and some of our discussion is we still believe that two-dimensional echo is still useful and predictive. And as the study showed, a 15% relative reduction in two-dimensional echo GLS is a predictor of future CTR/CD by increased odds of more than 133%. And it shows also the best area under the curve. We also, in that study, show like feature tracking strain is faster and also more reliable, and there's no need for additional sequence as opposed to the tacking strain. There will be a possibility perhaps in the future of doing only the LVEF sequences, only doing the CNE sequence and the short axis stack on MRI, and also the long axis in the apical 4 chambers, 3 chamber, and 2 chambers. And that doesn't need to have any gadolinium. And performing your feature tracking strain as post-processing. So acquisition of image would be about 15 minutes, and post-processing maybe another 15 minutes. And perhaps this could be used in case of serial MRI need for breast cancer patients to see if there's any response in the treatment. Perhaps we could do the CMR on a cardiac call versus if studies with future study, maybe breast curl for LVEF and GLS assessment. And additionally, this could be used, the CMR could be used as a confirmatory step in selective patients, perhaps patients that have not so good images on echo.
So what are some of the limitations for our study, which we just talked about? There's unclear validity of utility of strain in patients with decreased LVEF at baseline who have like dysynchrony, infarct, or regional wall motion. 3D echo is compared superior to 2D methods, so we still need more data on the utility of 3D echo measurements, and unable to perform CMR strain in patients who have a pacemaker and ICD is another limitation. And like we talked about earlier, we still need to use one method throughout the cancer therapy. And this another limitation is a relative short follow-up period. It's only 15 months post initiation of chemotherapy. And essentially this study shows a superiority of 2D GLS over CMR strain with tagging versus feature tracking. However, tagging is an old technique, and the newer strain techniques which are coming out with SENC and DENS, so we need more data on the utility of these sequences in predicting cardiotoxicity. And strain is, again, we need excellent image quality, and tagged CMR was not possible in 6% of the patients versus feature tracking on only 0.6%. and GLS with echo was not possible in 5% of the patients and GCS in 3%. So the strain data can only be interpreted in the setting of excellent image quality.
Thank you.
Thank you.
We'll take any questions now or any comments.
Guys, I see Dinesh is attending. Maybe since he's the king of this and has been the senior author in two of the major that you presented. Do you want to make a comment?
Joe, thank you very much, and to both of you, a wonderful overview of the paper. I think one of the things that I want to leave the audience with is, I don't want people leaving thinking that CMR strain is inferior to echocardiography strain, and that's one message we're trying not to propagate in the paper. What we're trying to show is that when you have a precise measurement of left ventricular ejection fraction using cardiac MRI, where the reproducibility is much superior to 2D and similar to 3D or better than 3D echocardiography, the additional value of strain as a prognostic marker seem to be less than with echocardiography, where we have a lot of challenges with the precision of the measurements, and hence if you have a more precise measurement or more reproducible measurement, such as strain, it seemed to have better prognostic value. If you have other cardiac MR strain techniques, would they be better? Potentially, but they have to be superior to the reproducibility of EF by MRI and EF by and volumes by MRI. And the other thing to keep in mind is that if you go back and look at all the strain literature that's been published, other than some of the work by Dr. Bonnie Key, we don't see really a comparison to changes in ejection fraction by echo. So, there's very few studies that have shown whether strain has incremental value to measurement of ejection fraction by 2D or 3D echocardiography. They all just look at strain as a prognostic marker. Probably appropriately so, based on the fact that we knew that the reproducibility of 2D and 3D EF, or especially 2D EF, was not that good, because much of the data has been based on 2D EF. So bottom line is that I think our data shows that the echocardiography measured strain seemed to have incremental value over ejection fraction, 2D ejection fraction measured by echocardiography, as well as incremental value over routine clinical factors that we have in these patients, whereas by MRI, it seems like the ejection fraction and volumes are sufficient. And I think one last thing is that I want this audience to understand is when we talk about strain, we have made this general statement that a 15% change in strain is prognostic. But we have never really thought about whether 15% is relevant 3 months into therapy, 6 months into therapy, 12 months into therapy, and whether the threshold should be the same. And we have assumed that it should be the same, and it probably is not the same. And I think that's one of the things that we have shown. I think you guys didn't have time to show that the cutoff data, but you'll see that the thresholds are very different depending on the time at which you're measuring strain. So, I think although we think strain is a great technique, I think it has important value, and when done well, there are some limitations that we have to keep in mind as well. So there's, I think, a lot more work to be done in the area.
Yeah, thank you.
I have two questions. The first is, you think that at some point it will, the strain and EF will go away and the MR volume, T1 and T2 volumes will be better prognostic indicators and ways to follow patients and make clinical decisions?
Joe, is that for me or for the group that presented?
Who understand?
I'm happy to start, and then we'll love the thought of both of you guys as well. So I think, Joe, if you can, I think your question is whether we think MR is really, MR and tissue characterization perhaps is going to be the way of the future, if I understand you correctly. Yeah. And I think, tissue characterization, I don't know is the honest answer. I doubt it's going to be the way of the future. That's sort of going out on a limb here, but I think looking at the tissue characterization data, the relative changes in tissue level markers in a context of cancer therapy, other than myocarditis, which causes significant injury to the myocardium, I think the degree of change is going to be so small that we're not going to have the precision to pick up a prognostic change, is my thought. With respect to volumes, and I think Dr. Hundley has shown several times in some of his work that volumes are important, especially end-systolic volume. The challenge is some of the work suggests something like a 3 milliliter change in end-systolic volume is prognostic. I think the challenge is, can we measure 3 milliliters in a precise manner? And that may be a challenge. But if we can add cardiac MR just volumes and function because of their reproducibility, I think it is going to be the best way to follow patients, although not a practical way because of the availability. And one thing we saw, Joe, in the Embrace MRI study is that, I would see every one of these patients we followed in our clinic, and we would see a patient who had a change in strain, and we would say, okay, let's look at the MR. And we would pick up the MR. There's almost always a fall in ejection fraction, by 3, 4, 5, 7%, and there's an increase in end-systolic volume. So, if we have the unlimited availability to follow volumes and ejection fraction by MR, I think that would be sufficient in my mind to follow patients.
Then I was thinking that if you could at the same time do an echo and an MR, and that the findings were compatible and similar, would you then use an echo strategy, maybe less expensive and there's more availability?
Yeah, I think that is hopefully one of the strengths of what we have been trying to do, Joe, is that that when we're doing MR and echo at the same time, our goal was not to tell clinicians, oncologists or cardiologists that we should switch over to doing cardiac MR. I mean that if that's available, great. But I think most centers like ours, it wouldn't be a feasible approach. So I think a diagnostic approach, Joe, using more than just two-dimensional echocardiography, strain or 3D is important. As you know, we have always thought about this as an individual parameter. We have depended on strain or EF or diastolic function or S prime velocity to help us make the diagnosis. I think that's the wrong approach. I think we need to have an algorithmic approach, which starts off by saying, what happened to 2D EF? If that didn't change, what happened to 3D EF? If that didn't change, what happened to GLS and GCS? And we have to be able to incorporate that in sort of a tree approach to come to the conclusion at the end. Let's say that 2D EF hasn't changed, 3D EF hasn't changed, GLS hasn't changed, GCS hasn't changed. The chance of the patient having cardiotoxicity is 0. And then, if you add the upper part of the node where a 3D EF, GLS, and GCS has changed, the chance of a patient having cardiotoxicity as defined by something like MRI is 100%. So I think that's the approach we need to start taking. And you're absolutely correct. I think what we hope to inform with these studies is that's a combination of biomarkers and imaging. So biomarkers, I'm talking about troponin, BNP, and imaging together, can that help us predict cardiotoxicity in an algorithmic approach?
Yes, this is Barry Trachtenberg here. So great job of summarizing the literature. Enjoyed the talk tremendously. I wanted to ask, really just put this out there about the, looking at the baseline MRI. We've shown and others have shown that baseline GLS can be very predictive, and on echo can be very predictive for future cardiotoxicity, and it's more in line of what we're seeing with kind of the two-hit hypothesis and the genetic predisposition to heart failure in some of these patients that develop cardiotoxicity. So has anyone studied or thought about studying MRI just at baseline to see more precise measurements to see if there's some abnormalities, and whether it's strain or volume or anything else, as a predictor of future cardiotoxicity, regardless of whether there's any sequential changes?
Barry, as you know, that the literature on strain for baseline prediction is variable, right? There are some studies that show that it is prognostic and others that haven't. And in our meta-analysis that was shown today, we actually did not show baseline strain to be prognostic. Although there's great data, like Mariel's work that looked at heart failure in the long-term population that suggests baseline strain is prognostic. In our data, when we break patients down, patients who develop cardiotoxicity do have statistically significant reduction or lower strain at baseline. But the difference in strain is like 0.9% absolute. So, my concern is that although as a population, we probably will show that baseline strain is going to be lower in patients who develop cardiotoxicity, like you said, perhaps because of the two-hit hypothesis. The challenge, Barry, would be that, can we use this at the individual patient level and identify patient at risk? And there, I think it remains a challenge, at least in our data with MR, baseline strain does not seem to be prognostic for cardiotoxicity.
Anybody want to comment on AI, artificial intelligence, and looking at echoes to predict cardiotoxicity? There's
Hello?
no literature about that. And is that ultimately going to be like a good screening, a good use of screening tool?
Hello? I have two questions for the two speakers. Congratulations, really, for your astonishing presentation to both of you. Agnese Maria Fioretti, Bari, Italy. How long does it take a strain MR? Mostly in comparison with the strain echo. Could it be a limitation, the duration of the exam? And another question, do you have data about the use of a strain MR in other anti-cancer drugs, for instance, TKIs or immune checkpoint inhibitors? Thank you.
Okay. But I can answer first of all for the time commitment. So if you were to use feature tracking CMR, you only need the cine images of the CMR, so the short axis to get the short axis stack, and also the apical 4-chamber and 2-chamber. And this would be post-processing assessment of your strain. Will be the same thing as the echo, where you take the 4-chamber, the 3-chamber, and the 2-chamber, and you perform post-processing. If you were to be choosing the tagging method, the tagging strain that Shri explained, it takes more time because you need to saturate the myocardium in a grid-like fashion. It's an addition of sequences and time. So that's the first part. The second part of the question, I forgot now.
Papers about other anti-cancer drugs.
So as far as concerned, I know that strain has been used for myocarditis in echo, and that's been predictive with the worst MACE in people that have myocarditis following immune checkpoint inhibitors. But for MRI and myocarditis or TKI, I'm not sure.
I don't know of any like large data which came out with other potentially cardiotoxic chemotherapy agents. And I think one of the challenge with CMR strain, which I think is because there's several different techniques, and now there are more techniques coming out with Senk and Den. So we just need more data about how these techniques are going to evolve over time and standardization as well.
Thank you. Congratulations to both of you.
Thank you.
And I think Dr. Carver was asking prior about AI.
Yes.
Artificial intelligence in I'm not sure about in echo or in MRI, but we do use artificial intelligence or partially for CMR, so in post-processing for the LV volume. But we do need to double check and do the contour. That's one of the example I can give that we use AI in certain program.
And also there are programs with AI which use with acquisition as well, but I don't think we're there yet where AI can do everything.
I think, Joe, if I could also add to the AI question, I think there are two approaches to the AI with this data, and one of the strength of deep data, with having echo, MR, biomarkers, and clinical follow-up is the ability to use AI. And like the presenters mentioned, we use sort of built-in AI for contour identification and function. But with respect to application of AI, there are sort of two approaches. One is you take all the data that's post-processed and have all the values, and then you use the AI methods to look to see, is there a prognostic signal? Is there a combination of certain metrics that identify patients at a risk of cardiotoxicity? So, we have been looking at T1, T2, ECV, echo strain, and all the echo parameters and biomarkers and clinical markers to come up with a potential prediction algorithm using AI-based techniques. The second approach is actually to take the raw data, and then you take your cine data, your mapping data, your echo data, and actually look at the images directly and see if there are features within the images that help identify patients at risk, whether it's baseline or at subsequent follow-up. And that's also an interesting approach, has been used, for example, to differentiate the different causes of hypertrophy. And that's also an area of interest. I think a few people have been looking at the data that way, and we've been doing the same as well, but no results yet, hopefully soon.
Any other questions or thoughts?
Always one more question we throw out. I mean, it's clear that there's better yield in high-risk patients. So do you think that we will reach a point in time where we say this person should have an echo, this person should have nothing, and this person should have CMR to follow their therapy?
Yeah.
I didn't hear. Sorry.
I'm assuming, I guess Joe is asking whether we should be using risk stratification techniques to decide what should be done in patients. Perhaps one approach is, low risk patients do nothing, intermediate risk patients maybe follow with echo, the high risk patients maybe follow by MR. And I guess he's just asking what you guys think about that kind of an approach. Joe, am I correct in interpreting?
Yeah, exactly right. There's a personalized monitoring.
Yeah. So I think biomarkers can be used in all low risk, intermediate, and high risk patients as well. And it's easier to be done because these patients get labs as well. And then the utility of using additional imaging with echo and MRI. If you have a good quality echo and a good strain which tracks well, personally, I think you could use that and follow up over time. However, if you have this baseline echo with relatively poor quality and poor strain, and if you have the capacity to do an MRI with strain, I would switch towards the MRI and use that for follow-up in these patients over time. That's my thought process, taking everything into consideration.
But I still think we need more data about performing a risk stratification or risk score. I think there's undergoing studies, I know by Dr. Bonnie Key, our group is trying to figure out a little bit more data on the baseline and risk factors to be able to follow these patients differently, whether they're on the low risk or high risk with biomarkers or maybe other images. But yes, that could be in the future, but I think we still need more data at this point.
Yeah, so there's an important, this is Jose from Washington. So there's an importance since when we talk about risk stratification, about making a distinction between patient-related risks and cancer treatment-related risks, and also where in the treatment pathway is a patient. For example, patients with breast cancer who are getting actual, the first year or the first couple cycles of actual therapy versus in the maintenance phase of trastuzumab, because they need 1 year of maintenance therapy. So are we going to be evaluating those patients in the same way, like every 3 months, or at that point in time after a year of treatment, and they're just under maintenance therapy, should we, if they've been doing okay, should we back off and doing less frequently? So just like you were discussing right now, I think that there's a huge difference if the patient itself or the patient himself or herself have a high risk from whatever traditional risk factors they could have at baseline unrelated to their cancer or cancer treatment versus patients who may have a much higher risk.
So, Sri, this is Dan. Sorry I was a little late there. And then I heard Dinesh and others a minute ago. I don't know if in the course of your presentation, if you talked about the different techniques for doing MRI strain, for example, and those are not available everywhere, obviously. But one advantage to some of the newer techniques is that it doesn't require contrast, and therefore, when you look at the overall expense of an MRI versus the expense of an echo with contrast and strain, then actually an MRI is less expensive than an echo. So it's sort of a urban legend that echo is less expensive, but that's actually not the facts. When you include strain imaging and contrast, you really increase the expense of that tool. So I don't know if you and Dinesh and others have comments about that.
I would
Yeah,
like to comment on this. Yeah.
yeah. So Dan, I'm with you on the cost. In the Canadian system, we have universal healthcare, and the cost difference between echo and MR is about, $200 for an echo versus about $270 for an MR. We don't bill for strain, we don't bill for contrast. There is a cost difference, which is small, but I think rather than the cost difference, Dan, the challenge for us is accessibility. If an oncologist needs to start a patient on chemotherapy on next Monday, and they need an echo, I can probably get it done tomorrow or day after. But I'm not going to be able to get a baseline MR in these patients, and I think baseline assessment is going to be important. So the limitation has not been cost, at least for us. It's been really accessibility and availability. And then with respect to the strain techniques, I do agree with you, Dan. I think there are differences between the strain techniques. I think what we need to understand is the reproducibility of all of these techniques. But also, more importantly, at the end of the day, we really need to answer the question, just like we had to in echo, whether it is going to provide incremental value over garden variety, ejection fraction, and volume measurements. And cardiac MR really has a tremendous strength in both of those measurements. And can any other additional method overcome that strength? I think that's something we would have to answer with all the ongoing work.
So
Yeah, I think those are good points. I would say that if you go back in time, for some of us, this was when we were in training, where pretty much all we did were M mode and 2D measurements, and they were doing color, but they hadn't really quantitated it all that much. And then over time, the Doppler techniques improved such that, you were doing tissue Doppler, and then it progresses on 3D and strain techniques, et cetera. So, over time, the echo techniques improved, and, it's like one of those things that, you're never going to go back. So I think that if we try to say that I'm going to do just a basic echo and all I'm going to do is measure 2D measurements, and I'm going to compare that to MRI-based measurements, then there really is no comparison. I mean, an MRI is a far superior test for that. And then when you start talking about these advanced imaging techniques, comparing echo versus MRI, I mean, and Dinesh, you would know this as well as anybody, I think that if you're directly comparing MRI to echo, then I would say MRI is going to be a better test because the technique is more reproducible. But I think that then the other factors of expense and availability really matter. And what you're talking about, whether you can get an MRI, if you could, you probably would do it. But if you can't get it, then you get some alternative tests. And I think that part of that is just understanding, do we really need an image, number one, and number two, what are our local availability and expenses? And at least in the US, just contrast on an echo is over $1,000. So, that's what that adds to the bill.
So let me, Danielle is still on. Has MR replaced or changed the way that you use biomarkers, or are you still making clinical decisions based on biomarkers?
So Danielle is muted. I can say that it depends on what your strategies are. I mean, I think when COVID was very prominent and we were trying to do everything not in person, then that's where biomarkers become critically important. And in terms of establishing cardiac safety, I think biomarkers can do that even without doing imaging. But when you start comparing these different techniques, that's assuming that you can do all of the techniques all of the time and show which one is a little bit better than another. But I think you have to adapt to your current situation.
If I can also add, Joe, I think, with the biomarkers, I'm talking about serum biomarkers, there are two questions. One is, does it have a diagnostic value, which means that the patient sitting in front of me today, and I've measured troponin and BNP, does this patient have cardiotoxicity? And the second is its prognostic value, whether a change compared to baseline or the measurement today identify this patient's risk at the subsequent time point. And of course, what we do with the patient depends on how we are using the biomarker. For much of the work that's been done by Daniela, Bonnie, and others, looks at the prognostic value of a change in biomarkers, and Bonnie has done some work looking at cross-sectional relationships as well, and we have done the same as well. Whether it's useful in cross-sectionally, I'm not sure, and that's sort of what Bonnie's work seems to suggest. But definitely, I think there is a prognostic value, which means that you see a change, like Daniela has shown in the ICOS 1 study, maybe that is time to intervene at the point. So that's, whether it changes with MR, in our MR cohort, we have also gotten biomarkers at every single time point. It at least for diagnosis, it hasn't been incremental to everything else that's available. But as Dan says, it depends on the expertise, and perhaps when we cannot measure EF, when we cannot measure strain or volumes, that biomarkers may have a value. But in our cohort, it's unclear at this point.
We would be remiss if we didn't emphasize that clinical decision making should be based on more than one parameter.
Yeah, absolutely. Yeah, and I mean, I think that, just like when we try to define any condition in cardiology, pick one like aortic stenosis. You think about aortic stenosis and you have a physical exam finding and it makes you think, okay, this is moderate or this is severe aortic stenosis based on physical exam. You do an echo and you have 6 or 7 or 10 different parameters that you look at to assess the severity. If all of those parameters are pointing in the same direction, then you're very confident that this is aortic stenosis and it's severe. But if 3 out of the 6 are not exactly very convincing, and maybe your physical exam wasn't all that good, or you did some biomarkers, or you did some other test, cath or whatever, it all depends on if all the parameters are pointing in the same direction. You're much more confident. if things are pointing in a variety of directions, then you're not confident. And so I think that each test and each set of parameters of one test have some value, and the collective whole, or the totality of the evidence, is what provides the most confidence in your decision making. So I think any one test, if you focused only on one test or one parameter of one test, then that's probably not looking at the whole picture, like Joe was saying.
Thank you so much for this wonderful presentation. My name is Prince. I just want to make a comment. I think earlier on somebody mentioned risk prediction and whether we should do these tests in a differential manner. And I want to even take it a little further. Cardio-Oncology is growing to become a global program. And there are some developing countries where even getting an echo would take you a month to do that. So if we are hoping to take cardio-oncology internationally into resource-poor areas, what are some of the things that we need to look at vis-a-vis MRI echo versus just regular risk factors that can be used in epidemiologic risk prediction tools? Any comments on that?
I'm happy to start. I completely agree with you, and I think a point really well made. And I think this is really a reminder to anybody working on risk prediction that there's that ultimate risk prediction model, which may include 40 variables, and then there is the more pragmatic risk prediction model, which uses 1 or 2 or 10 clinically available variables that are available globally. I think that approach is probably the approach that'll probably be used globally. The challenge is whether those can actually risk stratify patients appropriately. So I think a nice approach is the combination of ICOS and the ESC group published the ProFormas recently, which really look at the multiple 7 different drugs and use clinical variables. They only have ejection fraction in there and 2 biomarkers in there, and you could count the clinical variables up and decide if the risk is low, intermediate, or high. Now, to keep in mind that those were expert consensus risk scores, and they're not being validated yet. So the key is that may work, but what we need to understand is the low risk group low enough risk that we don't have to do much with them? And what do we do with the intermediate group? I think it's easy for the high risk group. So we'll hopefully see some validation in those models. Now, if you go and look back at other sort of pragmatic models, at least in the breast cancer population, there's the NSA-BP31 model, which used a combination of just ejection fraction and age. But there again, you need ejection fraction measurement somehow. And then there's this model called the ESAS model for early stage breast cancer, which uses clinical variables as well. So completely agree with you, but I'm not sure if the clinical variables by themselves are going to be sufficient to identify a low risk cohort.
Yeah, and I think that to your question, that's part of the reason why I would still say don't give up on biomarkers, because those are available at most any lab anywhere in the world. And I think if somebody's getting cancer treatment, they're going to be getting laboratory tests as part of basic safety. So I think that those should be available in most any place in the world, and as opposed to a sophisticated MRI, for example.
And remember, it's an individual patient with an individual doctor. Use your skills and the resources that are available wherever you are to take care of the patient. I oftentimes sit in front of patients and I say, what would I do if all of a sudden the electrical grid went out and you had no electricity? What would I do and what would I think of it? So I think that everybody develops their skills locally to do the best job that they possibly can.
Okay, well, thank you all so much for a great presentation. Sorry I missed the first part of it, so I'm sure it was great. I'll have to look at the video to see what you guys said. But appreciate all your effort, and of course, it's always great to see you guys. So,
Thank you.
Thank you.
You guys, thank you, everybody who participated. This is, and how we'll go.
all right, great.
Thank you so much.
We'll see you next week.
Yep. Thank you.
Thank you.
Yeah, happy holidays to everybody.
Happy Easter. Goodbye to everybody.